I would like to offer you the following disclaimer. We are not about to replace prevention strategies that are inexpensive, safe, and readily available everywhere with expensive antiretroviral therapy. We would like to synergize with them. And so I remind you that we continue to advocate for education, change in behavior, harm reduction, and we continue to invest on new strategies and vaccines, hopefully one day a cure and an effective therapeutic or preventive vaccine. As it is today, existing strategies have failed to contain the global HIV pandemic, in fact, even the local HIV pandemic in many areas. So doing the same all over again is not working. We need to do something different. At the time, in 2006, these thoughts were rather provocative, if not controversial. I'm happy to tell you that since then, this thinking has become the norm. Is there a proof of concept that antiretroviral therapy can stop HIV transmission? The answer is yes, a resounding yes. In fact, a very successful yes. And that is derived from the experience of treating HIV-infected women who are pregnant. This is Canadian data that shows in Canada the number of women infected with HIV becoming pregnant in the first decade after the 1990 years. And you see here that early on, the number of children born with HIV infection was growing proportionally to the number of mothers that were infected. This is the number of mothers. These are the number of children. The rates of HIV transmission from mother to child were in the order of 30 to 50% in the early days of the epidemic. As many of you may remember, in 1996, myself and a number of others, we discovered the so-called highly active antiretroviral therapy, in other words, the so-called cocktail or HART. And conveniently enough, we brought it to the world at the 1996 Vancouver International AIDS Conference. Vancouver 1996 was where this new treatment was adopted internationally and certainly in Canada. And you see that following 1996, here in 1997, 98, 99, and 2000, we have a changing pattern. More women infected with HIV becoming pregnant, less children becoming HIV infected as of those pregnancies. In fact, I have updated that plot here, and the red illustrates the number of children born with HIV between 2000 and 2008. We have virtually eliminated vertical transmission of HIV through the use of HART. This is a meta-analysis published July of 2009 by Attia, Egger, and others, and basically shows that in the absence of antiretroviral therapy, there is a substantial likelihood of HIV transmission, as illustrated by these dots here, which is proportional to the viral load in the HIV-infected member of the couple, the index member of the couple. You see that this, although it decreases with the lowering viral loads, it only gets relatively low at 400 copies or less, yet it remains substantial, as illustrated here, about 0.2 per 100 person years. In the situation where we have people treated, these are untreated individuals, when we have people treated with antiretroviral therapy, as you see here, immediately the estimates go down very, very dramatically. And I have copied here the conclusion of the study for you, which says that studies of heterosexual discordant couples observe no transmission in patients treated with antiretroviral therapy and with viral load below 400 copies per ml. However, the data were compatible with one transmission per 79 persons years. So, this is to say, the confidence intervals are such that we cannot rule out the possibility that one infection can occur. But as you can see, the number of infections that would occur would be, even within those boundaries, rare indeed. Why is this phenomenon? Well, very simply, because when we looked at the effect of antiretroviral therapy at the populational level, this is not a clinical trial now, I'm talking a true population analysis of the effect of antiretroviral therapy, you see that antiretroviral therapy has a very dramatic effect. This is data from the province of British Columbia, where we have only one place where viral loads are done. So these are all the viral loads done in the province over a given period of time. Before individuals start antiretroviral therapy, you see their frequency distribution shifted around the 100,000 copies of virus load. And you see that as people start treatment, whether it's 6 months, 12 months, 18 months, 24 or 30 months, really what happens is there is a very dramatic shift so that the median viral load here is now undetectable, less than 50 copies per ml. We have rendered a large pool of highly infectious individuals into a small pool of infectious individuals. This would be your so typical treatment failures or non-compliers. And so to highlight the point, most of these people carry wild-type virus. Most of the resistant virus is actually found in this range so that the biology of the disease works in our favor because those individuals that have resistant virus have lower viral loads and therefore they're less likely to transmit resistance. This is data that is now published in the European Journal of Infectious Diseases by my colleague Aranka Anema.
So the first point I want to make is that despite the fact that injection drug use represents is practiced by a very small segment of the population, it has huge public health impacts. And when we neglect the health of even a small slice of the population, we jeopardize the entire public health. And the Manif cohort 2000 provided us with, this was a recently published paper that made, I think, a very important point that does add important information to our view of drug treatment as HIV prevention. This study looked at both drug treatment participation and injection as predictors of poor adherence to heart. And what was found is, that those who were abstinent, represented here by the green bars, were very similar to those who were in either buprenorphine treatment or methadone treatment and not injecting. However, those who were injecting and in buprenorphine treatment and methadone treatment had twice the rate of poor adherence. So the point is that it's not just being in treatment that protects people, it's being in treatment and responding to the treatment and reducing and eliminating injection practices. This has implications for the promotion of medication-assisted treatment as a harm reduction modality, which simply focuses on the distribution of the medication. This is a point that I believe strongly in, that we can't lose sight of the fact that addiction treatment requires both the availability and appropriate use of medication, as well as effective counseling strategies. And the final bar here is simply those individuals who continued to inject and were not in treatment. And again, related to my concern about drug treatment as a harm reduction strategy, I just want to say, even the use of the word substitution, I think we need to move beyond the phrase substitution treatment and refer to these treatments as medication-assisted treatments, because drug treatment is more than simply substitution. Effective treatments use safe and stable dosing. Drug use is monitored.